Yeah. So I'm going to talk about the hypertension guideline, which is German in Europe. I'm also going to comment as I go through on any differences between the European guideline and the US guideline, and really try and emphasize why we think this guideline is important. All of the information I described is in the official publication, which is in the European Heart Journal and is free to download. There's also additional pocket guideline and an app containing all of the information from the ESC website. Now, I was pointing out to, you may not be able to see this at the back, but it doesn't really matter, I will describe it. I was pointing out to colleagues that there's been a big change in many diseases over the years, but one of the things that's interesting in this paper in the Lancet is that at the moment, ischemic heart disease and stroke are the '1 causes of death in the world. And they asked the question, what will be the #1 cause of death in the world in 2040? And the answer is ischemic heart disease and stroke. It's not going to change. So cardiovascular disease is still going to be the biggest killer in the world in 2040. More importantly, they then asked the question, what risk factors are going to be the most important in 2040? And hypertension remains the most important preventable cause of death now and in 2040. So this is a bit depressing because we're trying to deal with hypertension and improve it, but it's still a major cause. It's something we need to focus on, because alongside hypertension, you also have overweight, diabetes, and smoking, and most of the metabolic factors contributing to premature death in 2040. Now, when I was asked to chair the guideline, I spoke to the guideline task force before we started, and I said, what are we trying to achieve here? I know we're going to write a guideline, but there have been many guidelines written that have made absolutely no difference to the treatment of hypertension. I don't really want to spend the next 2 years of my life doing something that is going to make no difference. So we have to look and see where the problems are. And the problem is that still less than half of our patients are detected with high blood pressure, and only about 40% in the world are treated. And what's really disturbing is that of those people treated, only about 1/3 are controlled, which means that there's only about 13% of people in the world with hypertension who are detected, treated, and controlled. This is a disaster. I mean, and we have to do better than this. So we wanted to focus on better screening, better detection, and easier treatment, and better strategies to control blood pressure. Now, the first controversy from the United States was when they changed the classification of hypertension. I'm pleased to say Europe has not changed the classification of hypertension. In Europe, you are hypertensive when your blood pressure is 140/90 or more. And we call that hypertension because that is the level of blood pressure at which we would recommend treatment with drugs. We know that people with pre-hypertension or high normal blood pressure also benefit from lifestyle advice. Everybody benefits from lifestyle advice, but it's when you start treatment, that's what matters. And we treat everybody pretty much at this level of pressure. So that is the definition of hypertension, the level of blood pressure at which we should treat according to the guidelines. Now in the US, they have this here, high normal blood pressure here, called stage 1 hypertension. And they accept that most of these people will not be treated. They'll get lifestyle intervention. And only the ones at high risk will get treated. So they're not that different. It's just that they didn't really need to call this hypertension. If you measure blood pressure in the doctor's office, we know that some of those patients will not be hypertensive because they And we also know that some of the patients who look to have a normal blood pressure in the office will be hypertensive because they have mast hypertension. So the only way of solving this problem is to do more out of office, more home readings, or ABPM. And so here we have the equivalent levels of blood pressure to 140/90 in the office is the same as a 24-hour pressure of 130/80 or a home average of 135/85 to diagnose hypertension. That has not changed, but it's worth re-emphasizing because the guidelines now recommend more use of out-of-office measurement. This is the approach to screening. What we want to do is try and get all governments to introduce screening programs for adults. And what we've suggested is that if the blood pressure is completely optimal, we'd all love a blood pressure like this, then you probably don't need to measure blood pressure any more than every 5 years, providing the patient doesn't get sick in the meantime. If the blood pressure is normal, then every 3 years. But it's the people with the high normal blood pressure we're interested in because these patients are more likely to develop hypertension needing treatment, so they should have their blood pressure checked every year. And also remember that people with high normal blood pressure, about 20% of them will actually be hypertensive on ABPM or home readings. So these are the people who you might think about doing out-of-office blood pressure measurement. The other thing that's changed is that for many years, the diagnosis of hypertension was solely based on repeated office blood pressure measurements. We now say this can still be done if you can't access ambulatory or home monitoring, but this is superior. This allows you to get a more accurate diagnosis and also to exclude white coat hypertension and define mast hypertension. Before I describe the treatment of hypertension and the thresholds and targets, I just wanted to say 2 more comments about risk. The European guideline recommends the SCORE system to assess risk. This is a system that's based largely on European data, although there is a correction factor for the Asian continent. So it can be used there too. The importance of this is shown here. This is an illustration. So these patients have grade 1 hypertension. Some of them are low risk, some of them are moderate risk, some of them are high or very high risk. And your risk is determined not only by your blood pressure, but also whether or not you have hypertension-mediated organ damage like LVH or kidney disease, whether you have comorbid conditions like diabetes or kidney disease, or whether you have established vascular disease. So we need to know these things to understand whether or not only should we treat blood pressure, but also think about giving statins. And in the European guideline, we now recommend giving statins routinely to patients who are high and very high risk, even if their cholesterol appears normal, and even considering giving statins to all patients with hypertension, even people at low to moderate risk, because this will reduce their risk of heart disease and stroke. And I give most of my patients statins as well as lowering their blood pressure. What about low-dose aspirin or antiplatelet therapy? Well, the secondary prevention, patients with established heart disease, stroke, vascular disease, we recommend low-dose aspirin unless it's contraindicated. However, for primary prevention, even in people calculated to be high risk, if they don't have definite vascular disease, then we do not recommend routine use of aspirin anymore. And that's largely based on our review of the data, but also 3 trials that were published at the ESC in Munich, all demonstrating no advantage of low-dose aspirin. So that is over. And certainly not in hypertension, where the risk of bleeding is even higher. So let's look at the levels of blood pressure that we should treat. You will see that basically we divided this up into ages, so age 18 to 65 defined as younger, 65 to 80 older, and then over 80 very old. Although we accept that within these age bands, age is a some people can be old when they are relatively young, and other people can be young even when they're very old, depending on how biologically active they are. So, in younger people and people up to 65, up to 80 years, we recommend starting drugs at 140 night. That is the definition for treatment. For people aged 80 or more, we still be cautious about recommending treatment in all of these patients at 140 over 90 because the only real evidence we have in the very elderly is from HIDET, which randomized people at this level. So we've left that unchanged. But this is more aggressive because previously it was 150/90 and now it's down at 140. And even in very high-risk patients with chronic disease, we suggest you might even consider treatment at the high end of the high normal range. But that is relatively weak recommendation because the evidence isn't very strong. So this is what the treatment strategy looks like. People with high normal blood pressure get mainly lifestyle advice, measure their blood pressure every year, and you might consider giving drugs to lower blood pressure, particularly in people with cardiac disease, where the best evidence is. If you have grade 1 hypertension, lifestyle advice. If you're high risk because of established disease, chronic kidney disease, diabetes, immediate drug treatment. If you're low risk, but don't have any damage and no other risk factors, you could try lifestyle advice on its own for 3 to 6 months and then drug treatment if blood pressure is not controlled. If you're grade 2 or grade 3 hypertension, lifestyle advice and immediate drug treatment. And, importantly, get the blood pressure controlled quickly. We need to move from the idea that you start with a low-dose monotherapy, bring them back 2 or 3 months later, start another drug or increase the dose, bring them back another 3 months later. It can take a year or more to get these people controlled. We need to be faster than this because it makes a difference to outcome. So how low should we lower blood pressure? Well, this has been a big controversy. It's always a big controversy because we don't have enough data in this area. But the guidelines have become more aggressive. That's good because only about 2 or 3 years ago the guidelines became less aggressive, largely on the basis of a single trial called the CORD in diabetes, which suggested it didn't show benefit of more aggressive treatment in diabetes, and everybody panicked and started raising the targets and saying we shouldn't go below these levels. Then we got SPRINT, and everybody swings the other way and wants to lower everybody's blood pressure as low as possible. So we have to be careful and look at all of the data. Here's one paper that we published in the Lancet a year or so ago. This is an analysis of data from OnTarget and Transcend, which had 30,000 patients. And we asked the question, if you look at the achieved blood pressure, corrected for all factors, what is the primary outcome of cardiovascular death related to the achieved blood pressure? These two lines are between 120 and 140. It looks like there's a sweet spot that if you get your blood pressure somewhere between 140 and 120 on treatment, at least in people in this trial, that was associated with the lowest risk. And the concern was that if you look at some of these outcomes, including death, there did seem to be a trend for people who achieved very low blood pressures on treatment, where there was actually an increase in risk. So the way we analysed this is we said the optimal systolic blood pressure seems to be somewhere between 120 and 140, and it will vary from patient to patient. And there is a signal of increased harm when treated systolic is below 120. Now, that doesn't mean to say you should never have blood pressure between 120. It doesn't mean to say that if somebody is young and goes on a drug or 2 drugs and their blood pressure is 116 and they're very well, we should necessarily back titrate treatment. That's a good result. It's all about saying if you aim to get down below 140 and towards 120, but don't really push on more drugs to get below 120. You don't need to do that because there's no evidence that that is necessarily beneficial. Even in sprint, they didn't get below 120 on average of the trial. Now, diastolic is more of a problem. This is another paper we just published in the European Heart Journal from the same study group, where we looked at patients whose systolic is now optimal on treatment, and and we looked at the relationship of diastolic and chief pressure. What we found again, a bit like systolic, is that once your blood, if you're lucky enough to have a diastolic between 70 and 80, that seems to be the sweet spot. That is where you have the lowest risk. And there was a signal of increased risk if diastolic was below 70, particularly for MI and heart failure. But again, whether this is causal or whether it's simply an association with low diastolic, we cannot tell from this data. So this simply describes the targets. And the most important statement here is at all ages, the first objective is to get blood pressure below 140/80. Now that is more aggressive in the elderly. We never used to go to 140 in the 80-year-olds. We never went to 140 even in 65-plus-year-olds. So we have tightened the target. But this is the key message. Get people on treatment below 140/80. Then the next question is, how much below? We never said that before. We never told anybody how low to go. So we said that if you're younger, you might aim to get to now to 130/80 to the low end. And if tolerated, you might even go lower, but not usually less than 120. If you're over the age of 65, you might go down to 130, but you wouldn't try usually to get it below 130. And again, all of this is dependent on tolerability. And if you're over the age of 80, try and get down below 140, even aim to get down to 130, but not usually go. Now this differs from the US guideline. The US guideline is identical for this group. We say get down to below 130 if you can. But for the slightly older patients, the US guideline says still go below 130. I think it's too much. I mean, I think many patients will not be able to achieve that. And I think we're being more realistic here. And this is still a more aggressive target than we had previously. In fact, it's the most aggressive target we've ever had in the elderly. This kind of summarizes and says basically the targets are the same for everybody, irrespective of disease, apart from CKD, where generally we're not recommending pushing blood pressure too low below 130 because there's uncertainty about the benefit of lowering blood pressure more aggressively in kidney disease, particularly the risk of worsening the kidney function. So let me move to interventions, the most interesting bit in many ways. People have been debating the targets and threshold, but I get more interested in treatment. So, three things: lifestyle, drugs, and devices. So lifestyle is easy, one page, nothing's changed for many years, everybody knows. We should restrict salt intake, we should avoid binge drinking, moderate alcohol intake, regular healthy vegetables and diet, body weight control, regular exercise, and stop smoking. That is fairly standard everywhere. There's nothing here, this is not rocket science, this is relatively straightforward lifestyle advice. All patients with hypertension should get that advice. It's probably good advice for everybody in general, whether you're hypertensive or not. So about drugs, I mentioned that one of the really big things we want to do in this guideline is improve the control of blood pressure. So this is really radical. Start treatment in most patients with 2 drugs, not 1. Now that sounds pretty basic, but the reality is it's trying to shift the entire approach to treatment. It's basically saying that monotherapy is usually inadequate treatment for most people with hypertension. The problem is about a third of patients who start on monotherapy and are not controlled stay on monotherapy, and that they don't get escalated. Initial therapy with a combination of 2 drugs should now be considered the usual treatment, the usual care of hypertension. We want to rewrite the textbooks. We want to rewrite the teaching of medical school so that when people are taught, they say, well, actually, when you start treatment for hypertension, most people get 2 drugs straight away. And that will give us faster control, better control, and more predictable response in these patients. Now, when we first began discussing this and it went out to review, lots of people were coming back to us saying, oh, this is a bit too much. Well, what's the alternative? Leave everybody under control? I mean, we're trying to do something about the poor control of blood pressure. Last year we published this, which was one of the studies I led with Tom MacDonald and Maurice Brown, the Pathway series of studies. This was Pathway 1. Not many people heard about this, but this was actually a very simple question. Combination therapy versus sequential monotherapy. Seeing which was better at controlling blood pressure, but also whether it was tolerated. And we took people in midlife, people with basically almost grade 2 hypertension, and we started them on either an ARB or a diuretic as monotherapy, and that's the fluid and green lines. They were pretty similar to each other, but look at the effectiveness of initial combination therapy of those drugs. Much better blood pressure lowering, twice as effective in terms of the magnitude of blood pressure fall, and this was well tolerated. And by the end of 3 to 4 months, basically what's happening here is they're all on combination now, because these monos have now stepped up to dual therapy, and they eventually catch up. But this meant that the initial therapy treatment group with 2 drugs were controlled almost immediately. And we got 74% of people below 140 over 90, quite often well below 140 over 90, on 1 pill with 2 drugs. Now that is twice the rate of control in the rest of the world for blood pressure at the moment. So this shows that it works. Then people said, we haven't got outcome trials. What happens? Who's going to do an outcome trial with this? I mean, the reality is many of these drugs are now generic. Nobody's going to pay multi-billions of pounds to do an outcome trial. However, we have got some evidence. So there are a number of registries that have looked at this, where patients, by some physicians, are given dual therapy, and some are on regular monotherapy. And those on dual therapy ended up with less cardiovascular events in this registry data from about 1 million patients in Italy. But even more impressive in my view is this study from the United States. So this is managed care health insurance data, where they've looked at the outcomes, major outcomes in people with or without diabetes and CKD, in those given combination therapy as initial treatment versus the usual add-on approach. Look, every outcome is better in every group. And I always comment, this is 50% less events here. This is 75% less events. This is incredible. It's the same drugs, but basically starting with combination, within a few months, dramatic reductions in morbidity and mortality. Now, if you're going to give 2 drugs instead of 1, patient's going to look at you a bit disappointed. So, I thought I was just going to start on 1 tablet. Well, now you can. So the next bit of this is, let's use a single pill to treat hypertension. Because we've got single pill combinations available, and many more of them. Because we know that poor adherence to treatment is directly related to the number of pills, and a major factor contributing to poor blood pressure control. So, if we're going to give 2 drugs to start treatment, let's just give 1 pill, and give a single pill combination for the initial 2-drug treatment. And if you need 3 drugs, give 1 pill for 3 drugs as well, because we've got those 2. So here we have an opportunity to move towards a single pill strategy to treat blood pressure for everybody. Pretty much everybody will be in control. Now, about 10 years ago in my group, when I was in Leicester before I moved back to London, we set up a urine assay and we started testing all our patients because we were worried that why so many of them were not being controlled on many drugs. And then our colleagues repeated this in the Czech Republic. This is updated data that we just published last year in hypertension. We found that if you're on 1 pill, at least in the United Kingdom, less than 5% are non-compliant. If you're on 3 pills, 40% non-compliant. 40%. And this was the same in other parts of Europe, and it's been replicated by other studies. If you're going into these renal denervation trials and you're supposed to be on 4 and 5 and 6 drugs, almost all of them are non-compliant. So anybody you see, I say to the medical students now, if you see a patient in the hypertension clinic, they say they're on 5 drugs, they're non-compliant, if they're not. So, and that is pretty much that. So what this tells us is evidence. Patients prefer to take 1 pill. They don't care what's in it. They don't care if there's 3 drugs in it, 4, they just want to take 1 pill. They don't want to take any of it. If they've got to take any, they'll take 1. And that's what we're trying to get to, is simplifying the approach to treatment. And then finally, if you're going to use dual therapy or triple therapy, if you're going to use a single pill combination, you need to give some guidance to the manufacturers about what drugs should be in that combination, because they can't make combinations of everything. So in the NICE guideline 2011, which I shared, we came up with the idea of RAS blocker with a CCB or a RAS blocker with a diuretic being the core therapy for most patients. When I first used to start talking about that, I got a lot of flack from a lot of parts of the world. So, no, too simple. It's an insult to doctors. We need something much more sophisticated and complicated. We can't do something as simple as this. Patients will think it's too easy. So, no, this was the right approach. And what do we now recommend? A combination of ACE or ARB with a CCB or a thiazide-like diuretic is the preferred initial therapy for most patients. Those requiring 3 drugs, a combination of an ACE or an ARB with a CCB thiazide should be used. So it's the same. And it's the same in the United States. It's exactly the same recommendation in the United States. Now, what's missing is beta blockers. What we say here, beta blockers should be used when there is a specific indication for their use. They may be used first line as part of treatment in patients with angina, post-MI, heart failure, reduced ejection fraction, or when you need to control heart rate. But they're not part of the routine combination approach to treatment. And the American guidelines are even tougher. They say you only use them when they are guideline-directed indications. So we've got pretty much agreement across the world now that this is how we should treat hypertension, which is really exciting because we've got combinations of these drugs available in dual and triple therapy that make it work. This is the kind of data we looked at. This is a big meta-analysis by Etihad in the Lancet in 2016, comparing all the classes of drugs, showing that ACE and ARBs were broadly equivalent on major events and outcomes, and similar to the other drugs. The only outlier was the beta blocker, which was about 17% less effective at preventing major events, mainly stroke, and less effective at reducing mortality than the other drugs, for the same level of blood pressure reduction. So yes, beta blockers are great in specific indications, but not as the only treatment of blood pressure. So we came up with this justifies our treatment strategy, and we came up with this very nice algorithm that basically, for people with uncomplicated hypertension, most patients with hypertension-mediated organ damage, that's LVH, proteinuria, and retinopathy, patients with stroke, TIA, or patients with diabetes, or patients with peripheral artery disease. So this is pretty much all patients. Start treatment with 1 pill if you can get it, as an initial dual therapy combination of an ACE or an ARB with a CCB or a diuretic. I would generally use an ARB, usually with a CCB, but sometimes with a diuretic if there's an indication. And the only time that you would consider monotherapy is in very low risk grade 1 hypertension, where the blood pressures are not far from the target, or in the very old or frail patient where you're concerned about over-aggressive reduction of pressure. So you're really assessing biological age rather than chronological age. And if that doesn't work, guess what? You stay on 1 pill. And this is now a triple combination if it's available of the same drugs, ACE or ARB, CCB, diuretic. And if that doesn't work, we've now got evidence from pathway 2 that spironolactone might be the best treatment, at least for patients with normal renal function, 25 to 50 milligrams a day. And so most of the patients will be taking is 2 drugs, and most actually will only be taking 1. And they can still get a beta blocker to please the cardiologist if there's an indication for beta blockade. Now, does this work? Yes, it does. We've seen lots of evidence from studies. Here's one example. This is with the percent of patients achieving their blood pressure target with 2 or 3 drugs in combination as a single pill. So here we have, for example, low dose ARB olmesartan, low dose amlodipine, 5 milligrams, 20 and 5. Look at that. Half the patients controlled with 1 pill in low dose. Then we give the middle dose, 2/3 control. Then we give the full dose, 40 milligrams and 10 milligrams of amlodipine, and we get 3/4 control. That's exactly like our data that I showed earlier about the single pill that we just published for pathway 1 with exactly the same percentage control. control on a single pill. So here we have 3/4 of the patients with hypertension managed with a single pill of a dual therapy approach, and a CCB, and yet in the world only 35% control on treatment. And then if that doesn't work, we can move to the low or high dose combination with increasing dose of thiazide, and we get almost everybody controlled. And you'll notice there's only about 10% left who are not controlled, and they are the ones with secondary hypertension, undiagnosed secondary hypertension, or people with genuine resistant hypertension, which is a much smaller population than we used to believe. Now that we're using this more efficient strategy to control blood pressure. And if you have other conditions like coronary artery disease, kidney disease, atrial fibrillation, or heart failure, if you go to this guideline either online or in the publication, you'll see these other algorithms that have been designed to provide tweaks to the little changes, reflecting, for example, the addition of a beta blocker as part of treatment in coronary artery disease, the introduction of a loop diuretic in patients with a GFR below 30 in chronic kidney disease, and caution about using spironolactone in chronic kidney disease. In heart failure, the addition of a mineralocorticoid receptor antagonist and beta blocker with heart failure with preserved ejection fraction, and in atrial fibrillation, beta blockers again for rate control. So this is giving you an idea about how that simple algorithm might be modified for specific indications. I've mentioned resistant hypertension already, I've done that. So let me just say a word about diabetes. The threshold is 140/90. The target is the same as in non-diabetics. So if you're younger than 65, get down to 130 and go lower if possible. And if you're over 65, then get down to 130 is the general target for diabetes. And that again is more aggressive for diabetes than we had before. And I've already mentioned chronic kidney disease. Now let me finish with a couple of comments about devices. Because there's been the emergence of renal denervation and other device-based therapies. We looked at all of that data. And we gave it a class 3, and that caused a lot of controversy. Oh my God, this is saying do not use, but they didn't read what we said. Use of device-based therapies is not recommended for the routine treatment of hypertension. Who could argue against that? How would you recommend routine use of a device to treat hypertension when the drugs are so effective if we give them properly a single pill combination? But we say, unless we get more data from clinical studies and randomized controlled trials, and until we get further evidence regarding their efficacy and their safety, and who is actually going to respond to these treatments. So this is a call for more information. We're not saying the devices don't work. We're not convinced they all do, and we're not convinced they work in everybody, but we do need more data before they ever become considered alongside drugs as routine therapy. And that's the European position on this at the moment. For those who want more information, we have an excellent section on secondary hypertension, how to screen for it, how to detect it. A really good section on how to manage hypertension emergencies, with a lot of recommendations around the various drugs that could be used. Blood pressure management in acute stroke, in women, in pregnancy, contraceptive pill, different ethnic groups, even the effects of altitude on blood pressure, which I must say I was unaware of, but really quite marked pressure effects at high altitude. COPD, AF, anticoagulants, sexual dysfunction, blood pressure rises in cancer therapies, perioperative hypertension, etc. So quite an extensive document, some quite authoritative information about how to manage these different aspects of hypertension. Actually, when we were doing this, I suddenly realized how complicated hypertension is. There's a lot to it. I mean, it's really quite a big subject and goes beyond simple treatment of blood pressure. People always ask as well, when should we refer patients to hospital? Well, the ESC this will vary in different countries depending on how your healthcare system is set up. It seems like everybody gets referred to hospital in China, whereas, in other cities where you have more primary care-based structure, it will be different. Anybody with a hypertension emergency, anybody with suspected secondary hypertension, I think young people who have significant hypertension should get seen by a specialist. People with resistant hypertension, people in whom the assessment of target organ damage or hypertension-mediated organ damage might influence treatment. Patients who've got a sudden onset of hypertension when their blood pressure has been normal for many years. maybe they'll develop some complication causing high blood pressure. And last, I've been to a number of meetings, having debates with somebody who's become a close friend, really, and that's Paul Welton. So Paul is the chair of the American guideline, and I'm chair of the European guideline. We were together in this particular picture at a meeting in Japan at the Japanese Society of Hypertension meeting, and I'd just been called by the editor of JAMA to ask if we could both write an editorial or a viewpoint about the differences, the huge differences, he said, between the European and the American guideline. Actually, when we sat down to write as we were here, we actually came with this conclusion that the guidelines are actually much more similar than they are different. And I finished with this, that the Europeans and the Americans now say the diagnosis has a greater emphasis on out-of-office blood pressure. They both say we should be using cardiovascular risk assessment more and giving more people statins. They both say we have similar recommendations on non-pharmacological lifestyle advice, and we both recommend identical drugs, ACE/ARB, CCB diuretic as the core treatment strategy, and we both recommend the initial use of combinations of two drugs for the treatment of blood pressure when it's 140/90, with wider use of single pill combinations to improve compliance and lower blood pressure targets and lower blood pressure thresholds for many patients. The guidelines are very simple. The main difference was the decision of the United States to reclassify hypertension, but in reality that didn't make much difference to the decisions to treat, because most of the people called stage 1 hypertension don't get treated, just as they don't with high normal blood pressure in Europe. For those of you who like things very brief, and you just want to read one page, I was asked by the European Heart Journal with